So those who had joined us before, in the previous session, I was talking, my name is Ahmed Qazi. I'm one of the optometrists here in UK. And last talk that we did, it was on the case. So I'm taking you guys through a journey of glaucoma, a patient which we are handling, and we're trying to see how we manage our glaucoma patients. So there are two things. First of all, as discussed last time, the diagnosis of the patients, and then we need to manage our patients. So in our previous talk, we covered the case history, and that's done. And from Iman's presentation, again, the case that I made for the case history, that it is the backbone of our routine examination. So we can see from the presentation that Iman gave very nicely that case history is really, really important, and it starts the moment that patient starts walking towards you in the clinic. So, and with the case history, if you can win patients' trust, you can show them that you are listening to them, then the management program becomes a lot easier because patient then trusts you. So today we'll be talking about diagnostic tests targeted at the suspected patients, and from the visual, the low vision aid clinic that we saw from Iman, that if we can prevent the visual loss, that is a lot better than trying to manage the patients with very little vision. So, glaucoma, as we know, is something that can be prevented, or at least the progression can be slowed through various means, but the diagnosis is very important. So this presentation, I'm bringing you the diagnostic tools that we need to diagnose that the patient has got glaucoma or not. So then the next presentation, hopefully you'll join us again for that. We'll go through the interpretation of the tests, and also the assessment of anterior eye and optic nerve head, and then eventually the management of these patients. Okay, so let's get on to the diagnostic tests. So there are four basically main diagnostic tests that we need to perform on every patient, and one of them is intraocular pressure, very common, we all are aware of it. Then there's a visual field assessment, and we've got gonioscopy, not regularly performed in day-to-day practice. However, if you can master this technique, it's really, really important. Although anterior angle assessment can be done through Van Herrick's as well. Although gonioscopy is something that is very, very essential and very important. Fundoscopy, of course, to optic nerve assessment. So these are the four essential diagnostic tests. Then there are further tests that we can perform as well. I'll come to that later on. We're coming on to intraocular pressure. What we have is something called contact tonometer. And then there's another type, which is non-contact tonometer. There are two types of tonometers we have. Tonometer is the equipment that we use to measure the intraocular pressure. So this one is our gold standard. Nothing can be referred to ophthalmologists without having performed this Goldman tonometry on the patient. So I would appreciate if you guys can go over and revise once again if you are not aware of how to use this equipment, but this is our gold standard. Then again, second to that is Perkins, again using the same principles, but a lot more mobile and easy to use on patients who cannot reach your slit lamp or on the chin rest. So again, similar thing, I would say I love both these equipments very much in glaucoma clinic. And then this is the new toy that we all have. Is it contact or is it not? We can question that. I would call it a rebound tonometer. However, it still contacts the eye. And the patients love it, I love it, it's really smooth, really quick, and the accuracy is quite good as well. So I do love eye care quite a lot. I'm not promoting them, not being paid by them, but it is something that patients really love over the puffer test that we all do, which is a non-contact tonometer, and also does not require any anesthesia. So yeah, that's another very important and very interesting addition to our tools. Tono pen. This is, so again, a contact tonometry. It has got sort of a small cylinder under this blue cap that we have. So it again touches the front of the eye, and it's quite good. And again, needs anesthesia. So I have used it personally quite a lot. Then this is shots. It's quite an old equipment. You will see ophthalmologists use it quite a lot on their patients. I've not personally used it ever, but I've seen it being used. I am happy with the equipment that I've showed you already here. And if any of you have used it, please let me know in the comments. And it'll be nice to hear your feedback. How do you like it? And what was your experience like? Among the non-contact tonometers, we have, again, in the practices, you will see a Posterior right card. I've seen in a few practices. As a locum, when I'm traveling around, I see these basic equipment which are, commonly found. So Posterior is quite handy. Again, these non-contact tonometers, the advantage of that is it does not need any anesthesia. But again, I would say that eye care doesn't need that either. But these ones, they make the patients jump and they don't like it, and their accuracy is also questionable, and we have to double check with Goldman regardless. However, this is something that is affordable, and it is readily available in most of the practices. So yeah, that's non-contact tonometers. And if I could have polls just to see which one of you have, how many of you have used this shots tonometer, and also I would also like to see that which one is your favorite or most used Goldman. I don't know if Sean can put the poll on. Thank you, Sean. Have you guys used this shots tonometer before? Yes or no? I have not used it. But all right, so you've got 75%. Beautiful, very nice. So definitely you guys are more experienced in that particular tool, but very nice to know. And 25% have not used, and I'm among those. And we've got second poll I would like to know is, which one is your favorite tool? Which one do you like to or normally use most of the time in your practices? Is it Goldman, Perkins, all the list that you have there? If you could submit that, it's just to give me some idea that what our audience is used to. Right, hopefully the results should come up now. Thank you very much. So tabletop NCT, awesome. Yes, that's the most commonly used, even most of the practices as a pre-screening. And 18% Goldman, beautiful, excellent. That's really encouraging news. And eye care as well, 14%, very nice. Pulsar, excellent. And 11%, I'm quite surprised actually. Sure, so many patients, so many of you are using this equipment. Excellent. So it's a bit of a mix. Nothing, no particular preference on one particular thing. Right. So the next thing I would like to ask is if you would like us to show you how to use each instrument, and that way we can make another demonstration for you guys. Whether you would like another presentation, how to use each of these equipments in practice on day-to-day basis. Yes or no? That will be a future thing that we can arrange for you. And if you're already so you would like to know, okay, we'll see something that can be arranged for that. Thank you very much for that information. So let's go on with the equipment. The next thing that I have here, just a quick guide on a quick tour about Goldman. So this is the Goldman tonometer. You've got in two forms that you normally see. The first one that you see at the front is analog, and the one digital at the back. You turn the dials, and it gives the reading. First thing you do is make sure that your tonometer is calibrated. This comes with three, actually there's one middle line on the calibrator, and then you've got two lines on each side. So first and the second. So the first line after the midpoint is the 20 millimeters of mercury, and then the second line is 60 millimeters of mercury. If you guys want to make a note, but it's available on Google all the time, you don't have to worry about it. But this is something that is good to know, that the middle point that you see in the bar is 0, and this is how we can calibrate it. Again, in the video that you guys have requested, we'll see if we can make a video on how to calibrate and also use these equipment. When you're calibrating, make sure you use the prism which is provided by the Goldman, that comes with the Goldman, not the plastic ones, the toner-safe ones, and that most use the fluorescing dye, put it in patient's eyes, make sure you give them some tissue as well, because if they have watery eyes or runny eyes, it will be very difficult to perform the test. So once the patient's eyes are, comfortable, you bring that prism, a Goldman, close to the patient's eyes, close to the center of the cornea, and then you take your measurements. You will see this image through one of your slit lamp eyepieces. It's not a binocular view, it is monocular view. So you get the Myers, get them adjusted. Again, in the video how to use would demonstrate how to get these Myers exactly to this image. And then you need to clean the prisms, and Milton is something that we used to use here. However, nowadays, just to save the cross-contamination, the risk of cross-contamination and the hassle of cleaning, toner safe is quite a good thing. And these are just plastic tops that you can put on top of the prism and take your measurements. The quality of view is not as good as the prism that comes with the Goldman. However, it's quite handy and it's quite convenient. You just throw them away after one use. The next thing, once you've got the pressures, is to check the visual fields. Visual fields, you have various different toys. You will see a lot of different equipments. But this one is, of course, again, in terms of visual fields, this is the gold standard. Humphrey's field analyzer is quite good and it's quite readily available. Most of the hospitals use this, and even universities, you would see that prefer to test patients on this equipment. Second thing, which is very much, well, the good thing with Humphrey's field analyzer, it covers a vast visual field problems. It could be related to other things, neurological problems as well. But this FDT is a frequency doubling technique, and it's quite mainly targeted towards the glaucoma patients. So this is quite an advanced thing, and relatively cheaper and less space occupying. So again, a very good addition to the tools. And this is just the advanced version of FDT Matrix 800. I've not used the Matrix 800, but I understand what I've read about it. It seems like it's just an upgrade of FDT. And FDT is quite good. So these are some example printouts of these visual fields. And you've got here field analyzer. This is how the printout looks like. And then you've got FDT printout, frequency doubling technique. This is how that looks like. Just familiarize, because when, as an optometrist or as an eye care provider, you might end up in a clinic that has one particular set of visual fields. So don't get thrown back by the printout that comes out, because it has happened to me in the past. I was not used to Henson, and I was more used to these field analyzer Humphreys. It did throw me back. So again, this is the printout of Matrix FDT. But the main things to look out for is the pattern deviation. Again, when we go to the next seminar, I will be taking you through the interpretation of these tests. So then we'll go through that in a bit more detail. But today I just wanted to show you that different machine has got different printouts. And again, here, as I mentioned, Henson, that did surprise me once. But it is quite commonly used machine. That has different printout results. And then Dicon, one of my friends here in UK, I saw it in their practice, and again, it's still in use. I was quite surprised, but it is something that you will see clinicians are using. So if you see a patient field result from these machines, you should be able to familiarize yourself and see what are the basic things that you need to look out for. For that, you should join us for the next seminar, and we'll go through how to interpret these results. This Goldman perimeter, I've not used it in person, but it's quite an interesting tool, which is manual Goldman perimetry. Again, it has different field results altogether. And then we have another form, which is short wave perimetry. Again, something that I've not used or seen in normal practice. However, is again targets glaucoma patients. It's like blue on yellow sort of background, targeting the short wavelengths, and then has slightly more higher sensitivity to the results, as the research suggests. But interestingly, I've not seen it in most of the clinics. After visual field, well, after the patient has had their pressures done and the visual field is done outdoors, outside of your room, then they come into your room, and then you have to perform certain tests. For example, anterior eye angle assessment. You can do that with gonioscopy if you can get your hands, familiarize yourself with these with this lens, just like you struggled with Volk lens in the beginning as a student. I don't know about you, I definitely struggled. So to get that into my muscle memory, I had to practice daily. A lot of time, a lot of time was spent on getting used to my Volk lens. Similarly, gonioscopy also requires a lot of practice. So if you get yourself into a habit of having at least seeing one patient in your practice with gonioscopy, that will get you familiarize yourself with this tool quite nicely, and it's quite handy. It's quite useful for glaucoma assessment. Then you have Van Herrick. Is something that I use on every patient. It's quite handy, quite useful. It tells us if the angle is narrow or not, and personally, this is something that everybody can use and everybody should be using on every single patient. So if gonioscopy is not that easy, at least Van Herrick is. Then the patient is sitting on the slit lamp with you, then you take them to, then you pick up the Volk lens and check the fundus. So optic nerve assessment is again one of the most important things in glaucoma assessment, because if the progression of CD ratio, if the CD ratio is getting bigger, or if there is asymmetry in the CD ratios, more than 0.2 is something which is suspicious. We need to look out for, neuroretinal rim. Is there any notching? Is there any change of color? And also, is the disc looking too deep, too big? And there's certain features, again, when we go through the how to analyze the results, then we will talk about that later. But fundoscopy is very, very important. Why have I got 60D over there? Is because you have 90D, you have 78D as well, and I've got here 60D. This is my preferred choice for glaucoma assessment. And that's just because in Glasgow, I was with one of the consultants, so glaucoma specialist, and he mentioned to me that for glaucoma assessment, 60D is the best choice. And in our University of Bradford, they also mentioned that because the magnification is 1:1, what you see is actually the real image. Therefore, the assessment, especially the progression, is quite easy to manage, and something that if you can get hold of, get used to, it'll be quite good. Also, you will be able to assess whether the disc is too big or too small, and then the CD ratio in comparison to that. So it's quite interesting what I found, and I use it, and I quite appreciate the difference between 90D and 60D, and this definitely gives me a better assessment. Then pachymetry, intraocular pressure without pachymetry, I personally think is incomplete test, and that's because especially with patients with African background, we know that their central cornea thickness is thin. And therefore, if we're doing the intraocular pressure examination on them, and we don't have the corneal thickness measurement, then I think that's incomplete information, and you will not be able to say with confidence that you have managed that patient well, or this patient is out of danger, or I would still like to have this spirometry result along with the intraocular pressure. What is a normal average CCT, central corneal thickness? If you guys know, you can just drop it down on the chat box that we have here, or Q&A, but I don't have a poll for that, but it'd be good to know that you guys know about it. Right, the ones that I mentioned before, they were all the basic equipment that everybody should have. Now these are a bit more advanced equipments, like OCT and GDX. They're very good, very helpful, and personally, you know, if I see a practice that has these machines, I love to work there, and I love to see my patient in those practices, just because it makes it a lot easier for me to manage those patients. And oh, somebody has answered something. Nope. Okay, I thought somebody might have said what's the central corneal thickness, but nobody has. Right, so OCT and the GTX, very good tools for measuring the glaucoma structures, especially the ganglion layer. So ganglion layer is something that is very hard to assess just by looking with the Volk lens, whereas these OCT machines and GTX, they have got certain you know, tools with which they can tell you how much damage has happened to the ganglion cell layer, and it graphs it out for you. And then when you're progressing, when you're checking the patients again after a few months, it can give you a progression as well, whether it is getting worse or is it staying the same. So very good equipment if we can get hold of, but as I said, it's quite expensive. Let's move on to the next one. Anterior angle OCT. In anterior angle, as I said, gonioscopy is very helpful, but again, with OCT, it is comfortable for patient and it is comfortable for the performer, the person who's performing the test, and we don't even have to be qualified to do that test. So anybody from the reception can perform this anterior angle OCT for you, and you can assess the angle a lot easier as compared to gonioscopy. But gonioscopy is a very important skill. I think we should all have that, especially if we are trying to manage our glaucoma patients. But OCT, as I said, is slightly a better option because of the comfort and the convenience for patients. Right, minimum cost for these equipments. I've just basically Googled these devices and used equipment, just looking for the cheapest possible that we can use for our Vision Arcade team on ground. For example, eye care, Goldman tonometer, visual field, FDT or Humphreys, pachymeter, slit lamp, and gonioscope, and also Volk lens, and all that totals up to about £16,000. And this does not include all the fancy equipment. This is the basic minimum that we need to perform our diagnostic tests on the patients that are coming to our practices, or the team of Vision Arcade, which are working really hard to provide all the eye care facilities for the East African communities. So I would like to say that one of the feedback that we received was it's really good to see free educational material being given out, but you know, nothing is free in this world. So I'm not going to send you this bill to your house, but what I would like you to say, what I would like you to do is basically contribute either through your own knowledge, share what you learn from us, and also if you can be part of the team which is on ground and help them and be of some assistance so that they can provide their services and these cares to the patients and catch the glaucoma before it leads to the presentation that you saw from Iman, leads to low vision problems. So before the patient reaches to a level where they have to be partially sighted or severely sight impaired, we can control it and stop it from developing to that stage. But everything costs money, and of course, Vision Arcade, as you know, is a charity which also needs some support, our support, and we would like you to help as much as you can. Thank you very much for listening, and I hope you benefit, and we'll see you on next seminar.